recorded talk. You can play that. Good morning. I would like to thank the organizers, especially Dr. Ramakrishnan, for the invitation to participate at PCSI 2021. I'll be speaking on Cribriform ASD device closure. I have no disclosures, but I would like to acknowledge that a lot of the cases I'm about to show you in this presentation are from the work and experience of Dr. Bharat Dalvi. Multifenestrated ASDs can be defined as an atrial septal defect with 3 or more fenestrations, and these fenestrations are usually present in about 5 to 10% of all patients who we evaluate for transcatheter closure. Often these are also associated with an interatrial septal aneurysm. And as you can see in this pathological specimen, these fenestrations will often be within the septum primum. So, transcatheter closure of these defects is more challenging than the standard ASD, and there are various options we can try. If the satellite fenestrations are within a radius of 7 millimeters of the main defect, then oversizing the standard amplified septal occluder often will work in also covering and occluding the additional fenestrations. If we have multiple fenestrations which are close together, some authors have described a balloon atrial septostomy to tear these fenestrations and create a single large defect for which we can then use the septal occluder. But this tear is unpredictable and it's difficult to size. Thirdly, multiple septal occluders can be used if the distance between these fenestrations is more than 7 millimeters. But in a small child, using multiple septal occluders is not always ideal. There is a slightly increased risk of erosion. And lastly, the Oct Cribriform occluder is a good option in this subset of patients. So this device, the Oct multifenestrated septal occluder, is a device with a small central waist and 2 equally sized left atrial and right atrial discs. And this is the ideal case for this device, where you have multiple small fenestrations, sometimes with or without an atrial septal aneurysm, where this device will have a good result. So 4 sizes are available: 18 millimeters, 25 millimeters, 30 and 35 millimeters. And the naming is with the size of the discs. The delivery sheet size required is 8 or 9 French. And when we size this device, we have to take into account a concept of the steady rim or the fenestrated septal length. So authors have described the steady rim as the area of this atrial septum, which includes all the openings and the aneurysm and is solid enough to support the device. So if you see this schematic diagram, that is the steady rim there, and that is the steady rim in this diagram. And we describe similarly the fenestrated septal length, which needs to include all the fenestrations and the atrial septal aneurysm. And of course, in addition to this, we also need the measurement of the total septal length, which is the maximum measurement of the interatrial septum. And we believe that you need to take these measurements at 0 degrees, 45 degrees, and 90 degrees, and then take the maximum of these 3 measurements to choose your device. So the manufacturer recommends that this device can only be used if the distance from the central defect to the aortic root and SVC is more than 9 millimeters. And that's because the smallest device available is an 18 mm device. So we need to cross the central fenestration as per the manufacturer instructions and measure the distance to the outer rim of the furthest fenestration, and then choose a device which is twice of this measurement. The radius of the discs should not exceed the distance from the central fenestration to either the aortic root or the SVC. And based on these recommendations, this is the sizing chart which can be used. So if the distance between the defect and the aorta and the SVC is less than 9 mm, we should not use this device. Between 9 to 12, we can use an 18 mm device. And as that distance increases, you can use up to the 35 mm device. In our study, which we published recently, and this was exclusively in pediatric patients, we chose a device which was more than or equal to 1.5 times the fenestrated septal length, but less than the total septal length. Specifically, I would like to stress that in our patients, we chose to cross the defect through a central fenestration, but a relatively smaller fenestration, which was close to the major defect. And this is important, and it varies from the manufacturer recommendations. With this deviation from the standard recommendation, we felt that with the smaller hole, we could offer better device stability, as this is a non-self-centering device with a thin central waist. This is our cohort. So we used the 18 mm device in one patient, 25 mm devices were used in 10 patients, 30 mm devices in 4, and 35 mm device in 1 patient. So of these 16 patients who had Cribriform ASD device closure, the median age was 5 years with a range of 2.5 to 10.5 years. 11 of our patients had an aneurysmal interatrial septum. And immediately after deploying the device, there was complete closure achieved in 9, while 2 additional patients, so a total of 11 patients, had complete closure at the time of last follow-up. So at the most recent follow-up, 5 patients out of these 16 continued to show small, insignificant residual shunts of less than 3 millimeters in diameter on the transthoracic echo. Follow-up period ranged from 1 to 60 months with a median of 40 months, and we had no early or late complications. I'll just take you through our standard cases. So this is a case who had an atrial septal aneurysm with multiple fenestrations. And at 0 degrees on the TE, you can see that with the device deployed, the aneurysmal tissue gets bunched up in between, and there is a bit of intra-device flow immediately after deployment. Similarly, at 45 degrees, this is what the case looks like. There will be splaying of the discs around the aorta. And this is at 90 and 120 degrees for the same patient. This was a slightly more challenging case who had a large central anterosuperior defect, which was measuring 13.5 mm, and multiple additional fenestrations in the posterior-inferior septum. So with the sizing balloon across this anterior superior defect, you can see that we are not able to achieve stop flow, even with overinflation of the balloon. We are seeing that the additional fenestrations are significant. And as expected, with the deployment of the Amplatzer septal occluder, this is a 16 mm ASO device. You can see that there is significant flow in the posterior inferior septum. So this was then crossed, and we have now started deploying a 25 mm Cribriform ASD. We are also trying to capture the RA disc of the septal occluder so that we can sandwich the Cribriform device between the 2 discs of the Amplatzer septal occluder. So first we deploy the 2 discs of the Cribriform device, and then we come back and deploy the right atrial disc of the Amplatzer septal occluder to sandwich the Cribriform ASD occluder. So this is the final fluoroscopy before release. That's the release of the ASO, and this is after release. So on the transesophageal echo, you can see that the Cribriform device is sandwiched between the ASO, and this patient did not have any residual flow on follow-up. So I would like to conclude by saying that fenestrated ASDs can be effectively and safely closed in the pediatric population using the Cribriform ASD device. Residual shunts, although not infrequent, are insignificant with this technique.